I'd like to switch gears a little bit now and turn to HER2 positive metastatic breast cancer. It's been a real yawn lately, right? Only 3 FDA approvals in the last, 7 months or so. It's very exciting. We now have 7 FDA approved drugs that target HER2 for the metastatic breast cancer setting. So let's go over some of the new exciting data. And first, Claudine, some very exciting data relating to tucatinib. Can you talk about the unique characteristics of this drug? Go over the results of HER2 Climb presented at San Antonio, as well as some of the results relating to outcomes for patients with brain mets reported at ASCO. So not many questions in there for you to address, Claudine, but let's get it started at least.
Okay, so I think maybe we can start off with the results that were presented at San Antonio, which really sort of set the stage for this drug. So the HER2 Climb data were presented at San Antonio, and this was a randomized trial. Tucatinib is a tyrosine kinase inhibitor, and the randomized trial was really focused on, I think, a really relevant patient population, because for quite a while, as you mentioned, Sarah, we know what to do in the first line setting and the second line setting, but then it was sort of a free for all what to do in the third line setting in patients who had progressed post trastuzumab pertuzumab based on Cleopatra data on the adjuvant or neoadjuvant setting, and then post TDM1. And so what was really nice about this trial, I think the trial design twofold, was that all patients had to have received all of those 3 drugs previously. And then the trial also allowed us to do something very practical, which is to allow patients with brain metastases that did not require immediate local therapy to go on a systemic therapy to see if we could control the CNS disease. This was really based on trials that suggested activity for this drug and activity for some of the other TKIs in this setting, for Neratnib, for instance. And the trial also required in its eligibility criteria that all patients have a baseline MRI. So what it did is it picked up some patients who had asymptomatic brain mets, and we know that is a problematic issue for our patients, where they often have, with HER2 positive disease, CNS involvement. So the trial results were presented at San Antonio for the overall trial, and the randomization for this trial was really, the drug design was for the backbone of CAPE, trastuzumab, with either in a randomized placebo-controlled fashion with either tucatinib or with placebo. So the question was really, what does tucatinib add in this setting? And what the trial results showed for the overall parent trial was that there was a statistically significant benefit in terms of progression-free survival, but probably most importantly, there was also a significant survival benefit on the order of 4.5 to 5 months or so with the addition of the tucatinib. And when they looked at actually the percent of patients who had brain mets at baseline, this was very high. This was just under half the patients had brain mets at baseline. And this is in part because it reflected who we put on the trial, right? Because it allowed patients who had known brain metastases that were stable to go on the trial. So a large proportion of the patients with brain mets fell into that category. But there were also some patients who were not previously known to have brain mets who were enrolled, who were felt not to require immediate neurosurgical or radiation intervention, and patients who were known to have prior brain mets but had some progression of their brain mets, again, not requiring immediate local therapy. And when they looked at that analysis, they found that the drug also had activity in that subset of patients who had brain mets. And just to give a number on that, for patients that looked at the progression-free survival in the patients the subgroup who had brain mets on the trial, it was 25% at 1 year versus 0% of the patients on placebo. So what the presentation that Nancy Lin did for us at ASCO really focused on a related but separate question. And that was really specifically looking at the control in the CNS itself, not just control everywhere, but the CNS control with the use of tucatinib. And when you looked at CNS progression-free survival for the patients who had brain mets and brain mets that were measurable, she found a significant prolongation in CNS progression-free survival on the order, again, of about 5 months, and also an overall survival benefit in that group on the order of at least 6 months. And if you actually looked at the patients who had brain mets at presentation that were new, but the investigator felt that they did not require immediate local therapy, there was also benefit in that group to the same extent. So I think what it shows us is that we have very active agents that can help control CNS disease that are systemic agents, and that we now can think of agents that control both elsewhere and CNS disease for our patients. So very exciting findings, I thought.
And a great review by you. Thank you. There was a lot of data to go through there. Sarah, can you take us through the toxicity of tucatinib? Its HER2 selectivity makes it a very unique drug. Can you speak to that a little bit?
Sure. So, as Claudine had reviewed, tucatinib really is a very potent TKI that is more focused against HER2 than some of the other TKIs. So, for example, Neratnib, which is a pan-HER2 TKI, versus lapatinib, which hits HER2 and HER1. And I think the challenge with both lapatinib and Neratnib had been this inhibition of EGFR, which really has resulted in a lot of the toxicities that we've previously seen, such as rash or diarrhea. And so the advantage to tucatinib from a toxicity profile is that it is so selective against HER2 and really almost spares EGFR, so that we are seeing much less in the way of GI toxicity. So the major side effects that we saw, it did, interestingly, it was given with capecitabine, which does cause diarrhea and PPE, but we did see that those rates were just slightly higher in the tucatinib arm compared to the capecitabine trastuzumab arm. We also do see some elevation in liver function. So you can see liver enzymes go up, and sometimes you will even see this really random kind of blip in the bilirubin that can happen. It's not common, it's a rare toxicity, but you can sometimes see that happen with tucatinib and then come down. There is some increased rate of diarrhea, but it was mild relative to the capecitabine, combination that we're seeing. And so, overall, I think it's a pretty well tolerated TKI compared to what we're used to seeing with other TKIs. Again, mild GI toxicity, mild elevation in liver enzymes, but otherwise, I think well tolerated, no need for prophylactic antidiarrheal therapy. You can really just use, as needed antidiarrheals.
Great, great. And Aditya, I think it was really interesting the FDA approved it in the second line setting. So after patients have received a taxane and trastuzumab type of therapy, what are your thoughts on this? Are there any patients you would use this in the second line?
It's clearly an active agent, and personally for me, this is attractive for two reasons. One is that it has activity in patients with brain mets, where traditionally anti-HER2 therapies have not had so much activity that was seen with this agent. And the second is the excellent safety profile. So it gives patients an option to continue with a drug that is relatively well tolerated and could control brain mets as well. One thing that was pretty interesting in the HER2 CLIMB trial was that patients who developed brain mets during the study and then received local therapy were allowed to continue on. And in those patients who received tucatinib, they had a further delay in the development of additional brain mets. So it is an agent that clearly has activity in the brain, and we know that HER2 breast cancer is associated with brain metastases. So personally for me, this would be an agent I would be very comfortable using in the second line setting, particularly in someone who has a known history of brain metastasis.
Yeah, and I would say that the activity, although we're all very focused on brain mets, because that's a huge area of unmet need, nearly 50% of patients with metastatic HER2 positive breast cancer will develop brain mets. So this is an area where we need more drugs like this. But its overall activity, regardless of brain mets, was also pretty phenomenal. The overall survival in PFS and the intent to treat population was positive, as Claudine presented. Last question on this sort of niche topic of HER2 positive brain mets, Claudine. Neratnib also presented some data relating to CNS outcomes from the NALA study. And as we talked about, Neratnib has more toxicity due to the EGFR inhibition, but it is FDA approved in combination with capecitabine for HER2 positive metastatic breast cancer. Where do you see us using Neratnib, if anywhere, in light of the very exciting tucatinib results?
I think that you're asking a really important question, and one that we're grappling with as well. So, there certainly are data that Neratnib has CNS activity. There are data from the NALA study and also from some of the TBCRC trials that have looked and shown activity in the CNS for this agent. So I think there may be individual patients where we would think about it. It's also something to think of. Presumably, we're going to need to think about what's next after tucatinib. And obviously, we have no data to tell us how these drugs will sequence with each other. But I think you're raising a really important question. But I think it is important to remember that we have options here. And there are going to be individual patients where we would choose one over the other.
I agree. I agree. Okay, let's turn to another very boring drug. A very exciting drug, trastuzumab deruxtecan. Aditya, if you could speak to this, this is a really exciting molecule. Again, just very recently FDA approved. Can you tell us about the mechanism of action of this drug and the DESTINY-Breast01 results?
Yeah, absolutely. Trastuzumab deruxtecan on HER2 is a HER2-directed antibody drug conjugate. It has several unique properties. The first is that it has a proprietary linker, which allows for release of the drug preferentially in the cancer cells. And also, this agent has a bystander effect, which allows the toxic payload to permeate outside of the cell membrane and affect the other cells in the microenvironment. The toxic payload with this agent is a topo-1 isomerase inhibitor, so it's different from TDM1, where the toxic payload is a microtubule inhibitor. So in a number of ways, this drug is different than TDM1 because of the bystander effect as well as the toxic payload that it utilizes. So DESTINY-01 study looked at the activity of trastuzumab deruxtecan in patients with metastatic HER2-positive breast cancer who were heavily pretreated. I think the median number of prior lines was 6. So it was a heavily pretreated patient population, and in this setting, the activity of this agent was evaluated, and I've never seen such an impressive waterfall plot. The study showed that the agent was incredibly active with a very high response rate and deep responses in patients who were heavily pretreated. And the data were so compelling that the FDA provided accelerated approval to this agent for patients with metastatic disease. So I think it's an excellent option to have for our patients with metastatic disease. The challenge in clinic is the sequencing of the various agents that we have and whether one should use one agent over the other.
Yes, I agree. We don't have any data to guide our sequencing, and I think a lot of people are using presence or absence of brain metastases as sort of a litmus test of how to sequence tucatinib and DS8201, and there are a lot who wonder whether we should be looking at trials to combine these two very active treatments. I think there are some that are being planned perhaps. Sarah, can you take us through some of the important toxicities related to this therapy?
Yeah, so, in general, from a day-to-day basis, most people tolerate the drug pretty well. They do get some GI toxicity, so patients can have some nausea, some very low-grade, mild loose stool. It actually does lower your neutrophil count, so we can sometimes see some neutropenia as well. But I think the toxicity that, and should mention, can cause alopecia, so something to discuss with your patients too. But I think the toxicity that was a lot of attention was drawn to was the risk of interstitial lung disease. And, I think the reason this did bring out some attention was that there were 4 deaths on the trial due to ILD. And so it's about a 13% rate of ILD overall. And actually the majority of it was grade 1 and grade 2. But it is something I think we now are very cognizant of, given that it can be severe and can, lead to complications. So, I think it's been a challenge because, I think what we'd want to know is what are the risk factors for developing this, and can we re-expose patients to drug? So far what we know from the data is that the risk factors seem to be patients who are more heavily pretreated, patients of Asian descent and patients who received higher dosing of drugs, so higher than the FDA-approved dosing when was studied in phase 1 was associated with higher rates of ILD. And so, I think we don't yet have enough information about sort of pulmonary function testing in these patients. Could we predict better who's going to develop ILD if we had those kinds of tests at baseline to help us select patients? And so I think we're going to learn more as time goes on. But for the time being, we have to be very cautious about this. So if someone does develop, for example, asymptomatic ground glass changes that you're seeing on CT, it is important to hold drug and to monitor for resolution. And then if it resolves, one can reintroduce drug with a dose reduction. But if someone develops grade 2 ILD, so someone who's symptomatic, you do actually have to discontinue drug and treat with steroids. And I think, again, given the very outstanding efficacy from this drug with a PFS of, 16 months in someone with a median of 6 prior lines of therapy, I think we're really eager to figure out which patients we could reinitiate drug on with pulmonary toxicity. And so I'm hoping we will learn more. But for now, those are the guidances.
Yeah, I think it's becomes even a little trickier in the COVID era, where we can have cough and shortness of breath for an entirely non-toxicity related reason. So all of us need to have our radar up, certainly, when initiating any therapy that could cause a picture that mimics COVID. Claudine, could you speak a little bit about the data relating to the use of this drug for HER2 low expressing cancers? What are we seeing? We've got some early data relating to this.
So we have early encouraging data suggesting this drug has activity beyond what we would think of as a traditionally HER2 positive. So the HER2 low expressing, so the IHC1 pluses or 2 pluses that have the tumors are not amplified by FISH. And there is an ongoing phase 3 trial to address the activity of this drug. And as Aditya mentioned, there is an interesting bystander effect, and some of the questions around why it may have this activity is based on that bystander effect. I think practically speaking, it's a incredibly important trial for us to accrue to. I think that in the clinic today, I think we probably all have some patients who have these tumors that are heterogeneous, that we've done various biopsies at various times, and they've had HER2 positive in some, but HER2 low in others. And those are patients personally where I really think about using this drug with the thought that I would have activity or have the potential for activity in the different clones of the tumor.
Yeah, I agree. I think it's an exciting, and a very exciting drug, as is tucatinib. And I'm really looking forward to seeing the data as well in HER2 low, especially triple negative with a HER2 1+ and 2+. My hope is that we'll have some efficacy there.